Welcome back. Hope you had a great lunch. It's my pleasure to introduce Dr. Michael Hinckley. He is with Wildwood Farms in Connecticut, and he comes recommended by MHA board member David Cunningham, who is with Augustine Recovery.
Hi, everybody. Well, we're gathering today to have this understanding of the importance and the various elements of creating a queer environment, a gay-specific environment for the LGBTQ community. And as we do that, I'd like to just introduce a couple of little aspects of myself. These are my two puppies here. The gray one on my right there is Cappuccino. She's 9 pounds. She's a Morkie, and next to her is her brother, which is Macchiato, and he's 8.5 pounds. So these two guys are my special friends my husband and I have here in Connecticut. One of the axioms that I picked up many years ago when I was a young student in Rome at the Vatican was this idea of the glory of a higher power is when the human person is fully alive. When I'm talking with clients, I often say, live with both lungs full. Our objective in addiction treatment and psychotherapy is always a fullness of life for the client to really be able to be engaged with their loved ones, engaged with work, getting back to hobbies they love, reconnecting with who they are personally. We're going to see a few things here today that are specific to the gay community, the LGBTQ community, the lesbian community, the trans community, the non-binary community, and how these particular issues that tend to be more under the surface, more unconscious issues, things that tend to be more repressed, are more difficult for the LGBTQ client because of various factors of what it's like to grow up LGBTQ. So there's societal, oppressive, discriminatory experiences that cause a reaction in the LGBT person, and then the LGBT person has issues that they put under the surface. And so these repressions get pushed down even further by these societal factors. And so one of the things that's very common we're going to find is that to help this person be fully alive is a challenge. And my response to that challenge is queer normative. Let me put it this way. I have numerous clients coming through Wildwood Farm here in Connecticut who are in the LGBTQ community and have been in treatment 10, 15, and it's not out of the ordinary to be 20 times in treatment and only be 24 years old. And nothing seems to have moved forward. And then when they come to a situation where the norm, it's normative to be LGBTQ, something snaps and they're able to make progress not only in the addiction, but in co-occurring issues that they have had a hard time addressing elsewhere. So here's our objectives today. I want to provide some insight and implementation tools on how to integrate specific guidelines and recommendations, actually mandates from SAMHSA in 2013 regarding the LGBTQ plus community. I want to define and explain what I mean by queer normative. It's our trademarked method as it pertains to programming, milieu, and the treatment planning for the LGBTQ client. I want to also help you understand the experience of the queer person in relationship to family and how that is navigated by both treatment professionals and by the client. And I want to spend some time about talking about queer resilience in the family system. So these things all put together we're going to talk about under the umbrella of a queer normative methodology. Now, the basic principle, the foundation of a queer normative environment, what we're shooting for is to understand how to build pride in the client individually. So what we're doing is we're going to develop a milieu, develop a rapport, the contract between the clinician and the client. We're going to have a family system work, but it's all going to be directed towards a healthy pride that the client will discover for themselves. Now, what we're trying to do is understand what has been the blocking to pride, what has kept this person from living, instead of centered in shame, being centered in pride. And so what has reinforced shame is that being queer, being different from other people, being asexual or a gender minority is reinforced by society. From every kind of experience, both in school and at work, within the family, it's reinforced that this person is different, separate from everybody else. And the person is going to end up blaming themselves for these distinctions, for these separations. So not only does the LGBTQ person feel separated, but then they start blaming themselves for that separation, blaming themselves really for their own sexual and gender identity. Now, here's one of the hardest parts about this shame that they carry. When we carry the shame, we develop a natural propensity to secrecy. One fellow colleague said it this way: when you're dealing with an LGBTQ client, you're dealing with someone who's professional at keeping secrets, that they have had to do that to feel safe. In order for them to feel safe, they've had to be secret about who they are sexually, be secret who about they are gender-wise. Now think of this, the greatest force in an adolescent's life, the greatest deal through the changes in life that happen in puberty is the sexual part to one's life. And yet this must be a secret. So there is a tremendous pull for safety, right? This is a matter of life and death to the LGBTQ person, that they have to know how to be secret. Any clinician can be fooled. If you have an LGBTQ person in front of you, you may or may not know. Because this pull to keep things a secret is a matter of life and death. What does this do to the person? It causes tremendous isolation. So part of what's keeping a person from having pride in themselves is this compounding of isolation, which causes the person to feel detached from others. And in fact, some would point to this as part of the trauma of being LGBTQ. That the isolation causes the trauma and actually causes issues of attachment. There are some studies that are starting to approach these issues, like in the experience of long-term queer relationships and the difficulty of attachment within the family system. Social exclusion occurs. A gay person, a queer person, a trans person does not need to be told that they're different. They carry that within themselves. So social isolation and exclusion is automatic. Remember the guys talk in the locker room? That automatically is an experience of exclusion for the LGBTQ person. Along with this, you have stereotypes. right? When I was young, the word queer was a negative. Today, it's rather just a common phrase that refers to LGBTQ. But queer was a negative phrase. It was a stereotype. Fag was another one. Limp-wristed. These images of being weak were stereotypes. So to be, for example, in my case, to be gay is to be less masculine. Stereotype. Discrimination. It doesn't take much to realize discrimination, especially in the example of a trans person. We're very lucky here at Wildwood Farm in the town of Madison, Connecticut, because socially the town is very accepting. You know, we have had trans clients regularly take jobs at coffee houses and beauty salons and the grocery store, or reading at the library, and able to have a job, feel proud about it, and interact with the public in a way that is great self-esteem building. But that's not always the case. Many times the stereotypes lead to very clear discrimination. We'll go through some of those numbers shortly. 43% of the LGBTQ population report using substances to cope with the stress of oppression and discrimination. All these things put together, 43% of the gay community, the queer community, trans community, 43% of everybody says they use substances because of the stresses caused by these elements. Now let's pause for a moment and consider what it's like to be that queer person, that gay boy, that trans little girl. It's an understatement to feel like the black sheep. It's an understatement to say that you feel absolutely different from everybody that you've ever met. In fact, you don't know anyone like you many times. Well, that may be changing today in the media. Many, many people still grow up with the idea of such a profound isolation that they are the only black sheep they know. And all of those issues get compounded and internalized. And the person learns how to hide among all the other white sheep. But wait a minute. What if we turn things around in queer normative theory? And instead of talking about a black sheep among all those white sheep, talk about black sheep among black sheep, making it the norm to be a black sheep. Make it a norm that everybody in the treatment program is LGBTQ. I don't mean just that it's welcoming and friendly and we're competent at doing psychotherapy. I mean the value of having LGBT people understand the isolation, you're in treatment together, you're being helped and guided by professionals who have also been through the experience. You're finding healthcare professionals that talk your language. This is rare in the queer person's life. And when there's a place that distinguishes itself like that, it becomes very special in the LGBTQ community. This is the motivation behind developing Wildwood, is building a place where that queer person can come and they can be a black sheep among black sheep. Now, if you know anybody in the gay community, they're going to know my next point. There are certain places where you can go where it is very acceptable to be queer. This happens to be a picture of Provincetown, Massachusetts, out on the tip of Cape Cod. Here in the Northeast, it's known as not just a great arts community from a century ago, but it's also a mecca where a gay person can walk down hand in hand with her lover. A gay man can walk hand in hand. A trans person can feel totally fine dancing on the floor with their partner. It's a place of acceptance, and it's black sheep with black sheep. And when you're like that, all the oppression feels to melt away, and there's a special feeling. San Francisco would be another place. You ever hear of a gayhood? Well, it's the same thing. Gay people wanting to be gay people. We've seen this across our country in different times in history. We've seen it happen with immigrant populations or other minorities coming together and forming a community so that they can escape the oppression and the isolation. And when they do, within the safety of that community, black sheep among black sheep, professional healers that know your language, there is an interior freedom that develops, and the person is able to be fully alive. This is our ambition. To create that milieu, to create that therapeutic environment where the person finds freedom to be their authentic self, to be who they are, to be who they're meant to be. Only then can one really address addiction and co-occurring issues. Now, as we move forward, we have to understand that the individual who's going through this experience of isolation, oppression, being pushed aside, is doing it as an individual, right? That this is an individual who is having all this force happen to them. And while they might find freedom in Provincetown, they are doing this all as an individual. It's one black sheep. And that as we look at the dynamics of family systems and the individual and the relationships around them, we first have to therapeutically understand the authenticity of the individual. Then the person, and we could take, for example, a trans person, then the person goes out and we start to look therapeutically at the family system. And that family system for the queer person is unlike any other clients you have. The family system is going to have a history of isolation. There's going to be a history, positive or negative, about the family's acceptance of having a sexual or a gender minority member. And so the family system is going to have to adjust, unlike any other system. Any other member in the family has an adjustment. So, for example, if there is someone who comes back from war and has PTSD, the family system will adjust for that person, and so that that person feels that they fit in. For the sexual minority, the adjustment is going to be positive or negative, but in many times requires the individual to not only have this family system, but to turn away and form a new system. We call that a family of choice. And so seeking out others who are black sheeps, the LGBTQ person is now going to look for support emotionally and morally with other members who will support them. Excuse me. So when the individual starts to form these family systems, there is a need being answered. Need for intimacy, a need to find comfort, maybe even relief from the pressures of the oppression and the discrimination. But the person will have to work on this in therapy. So we move from just working on the individual to family systems would have to be both the family system of birth and the family system of choice. Then we want to move therapy or milieu considerations on to societal factors. What's it like to be LGBT and have a job where you have to interact with people at the grocery store? And you're going to be as authentic and centered as you are. You're going to authentically accept the fact that your gender or sexuality is unique and beautiful, but different. You're going to accept that, and you're going to lovingly engage with the world around you, society. One of the great ways to do this, actually, in our program, we find, is through the 12-step community. To engage the 12-step meetings, to try to come closer to understanding how they fit in to that system, and how they fit into the 12 steps, and how they offer a new way of looking. And the reason why I focus on the 12 steps is because it is a community, no matter where you live, that you'll be able to find. And then beyond this societal experience, whether it's in the local job and the 12-step community, there's a wider world. And so we want the individual who has been so isolated, so trapped in themselves, if we're going to help them be fully alive, we now want to bring them into touch with, what are the issues of the world? How do I relate to what's happening in the Sudan? Or how do I relate to global warming? How do I relate to what's happening in my country? I matter. So my opinion in these things are important. And so now we have to encourage the person to really grow in their ability to understand that this is who I am. A person that matters, who happens to be LGBTQ, and has important things to think and say about not only their society, but the world around them. This may be the first time that they have been told that they matter in this way. Both lungs, fully engaged, fully living authentically. What we're basically doing is trying to take away negative coping skills, things that pushed people away, that encouraged isolation, and replace them with authenticity. This is who I am. All I am. Love me. And these are my thoughts. These are my feelings. Living authentically, fully alive. You know, there's a famous moment in Oscar history that I like to point to. The great actress who was the flying nun, you know, when I was a kid. And she's there to receive her award. And her name is called, and Sally Fields goes up to the microphone, and they give her the paper and the statue, and she just holds the statue, and she shakes it as she looks around at all the other celebrities that she's known her whole life. And this is all she says. You really do like me. Perhaps all the facades she knew in her life as a celebrity, all of those things that she put up in being the darling of Hollywood. And there she is with her lifetime award of the Oscar. What a monument feat. And she takes that Oscar and believes it to be an affirmation of being liked. Every human being yearns to be liked and wanted and loved. That's what being fully alive is like. So many people that we treat go without that deep, affirming care and love that we mean to bring. But if we're to do it effectively, we have to understand the negative coping skills, the negative societal and emotional experiences that they have had. And in this case, unique to the queer person, so that they may break free. And just in that moment, like Sally Fields did, feel the love. Let me give you an example of a young gay male. If a young gay male is coming into my office and I know that he's coming in with a meth addiction, there is most likely that this man has been involved in group sex and there's a lot of shame built up there. There's a possibility with young men that there is also some very challenging crimes that have been committed. And I'm not saying it's just men, I'm not being sexist, I'm not saying anything. But in general, I have to be open to this fact, because that's what comes with drug use. A compromise of moral judgment, a compromise of the inability to see that there are choices that bring me to greater life, and there are choices that bring me deeper and sink me in down deeper into the negative life, the shadows. I have to be concerned for his health. The queer community, HIV, communicable diseases, perhaps having a diagnosis and not receiving the proper meds or being stable on the meds. Not uncommon at Wildwood for us to have a group where people are around and being very honest, and someone says matter-of-factly that they were involved in group sex. And it is completely normal and accepted, because that's what comes with drug use in the queer community. The number one source of income for a transgender female in the United States is sex work. A young gay male who's involved in meth parties, doing chemsex, can go missing for days, have not just blackouts, but days of irresponsibility. So they have to deal with the shame that comes from not showing up to work or not taking care of family commitments for days on end, and what this does to them mentally. And yet underneath all this negative behavior that we could point to, the person is feeling greater and greater shame. And underneath it all, just in the example of Sally Fields, he just wants to be liked. He just wants somebody to see that he's damn good at baseball. He wants somebody to say the paintings he paints are worth looking at. All of these things that we might find as an expectation or a possibility with a young gay male. They're not okay, but they're not a surprise either. They're to be expected. My experience is that clients can be further addicted to not only the drugs, but also the sex, obviously, and then the whole lifestyle that goes around it, the drifting, even the homelessness, the violence. These all can be part of the process of addiction, and they can be addictive themselves. And so when someone gets clean and sober and they come to a treatment program for an extended period of time, they have to adjust all of these instincts within themselves. And so that's why it's not enough just to give them educational groups on addiction. It's not just enough to help them with their schizoaffective disorder, but they have to have an environment that allows them to reassess how they are in themselves, in their family, in society, in the world. This is especially true for the gay community. Let me give you another example, kind of a touchstone, show you how this kind of works. I know the screen, it's small and hard to read, but I want to tell you about a young trans female woman who I had the privilege of working with, and she is a great person and ally to our program. Imagine, if you would, having a secret. A 20-something client who has had years of an inner life as a complete secret. Best friends, parents, siblings, aunts, uncles, anyone, everyone is kept in the dark. This is a complete secret. No one on earth knows that Becky has a secret name. A name that Becky keeps deeply treasured in her, identifies within herself. She has secret clothes and magazines, special objects that embody a secret. One day, this young woman comes into my office and says that she thinks she might kind of be interested in living as a trans person. First instinct, if we're going to be queer normative, being gay, being trans, lesbian, non-binary, doesn't matter. You're the norm. What you're going through is what we're all here for. What you're going through, we are with you in. What you're going through, we have been through. Maybe different ways, but we're with you. So the first thing that I say to this young client, Becky, who's sort of interested in trans, would you have a special name that you'd like to use here in the privacy of this office? Glowing, just feeling overwhelmed, beaming like with such pride. Walker. My name is Walker, and I'd like to use it. That secret that was kept from everybody on earth was now out in the open. There's a tremendous breakthrough. And she's living in a milieu that says, wow, let's celebrate. Wow. The sober coach is going to talk about one thing at a time, maybe representing herself properly as Walker, going by neutral or male pronouns of her choosing. And then subsequently wanting to represent also her authenticity around the house at the farm, or maybe representing authentically at an AA meeting. Maybe first choosing an LGBT meeting, and then maybe a general public meeting. Maybe Walker will eventually want to go shopping at the thrift store and put on male clothing so that his authenticity from within that has been kept secret all these 20-something years is now out in the open. Only then, my friends, only with that freedom and that living out of life is Walker able to ever have the experience like Sally Fields. You really do like me. Freedom, authenticity. Only here, my friends, in this queer normative milieu and therapeutic setting, is this person able to come out and actually understand what is being said about addiction and co-occurring disorders? Because now they're being authentic. Now there's a real person in front of you versus a secret. Now a clinician can really engage. That clinician, especially knowing the language and the experience of being LGBT, is going to engage even further. What SAMHSA was asking for, here it is. A person being authentic, able to feel that natural primal want to love and be loved. Powerful. But it can only happen if we approach the client on the client's terms, understanding secrecy, oppression, discrimination, shame, with the objective of going towards pride. Now, how do we do this? You know, it's not all magic, hocus pocus, you know. It isn't, I remember when I was first a clinician, everybody liked to carry around a toolbox and say, everybody's got a toolbox, right? Find your tools, and this is how we're going to get recovery. It isn't in a toolbox. It isn't a trick. It's methodical and very basic to set up a normative experience where this person's truth, this person's authenticity is dictating treatment. Not what a heterosexual person is saying is the best way to treat a co-occurring disorder. It isn't going to last. The first principle that we must understand in order to have a queer normative experience is safety first. That person living in secrecy and isolation, oppression, that person plagued by shame needs to feel safe. This is going to be the first time, queer normative is going to be the first time that they have the experience of being in the majority. The first time that they're going to feel some kind of connection to other people, feeling a love that, wow, I don't even know this person, but I'm feeling something powerful. I've got clients that have not wanting to come to treatment. And as soon as they start to feel the interconnection of other people in the farmhouse, right away they start to say, there's something here I haven't experienced. The average length of stay, 6 months. They come and they stay because they're getting nurtured in a way they hadn't seen before. Conscious or unconscious. The core of an LGBTQ client's motive is that need to be safe. If safety is not their experience, they're not going to be able to progress in that liberation of authenticity. Now, how do we get, if we're going to be in the direction of and have the objective of pride, healthy pride for the client, what policy, how do we come to this? And what we basically have to do is we have to pay attention to what the research is saying and what professionals have been saying. And I hate to say this, but research and the SAMHSA made this all clear back in 2013 with impact in some areas greatly. So they have this guide for the clinical community. I highly recommend you reaching out and getting it. I believe it's available for free. And just a quick overview of what they're asking providers to be aware of is some variables like, what is it like to come out? What is the psychological, societal experience of coming out? Families of origin and families of choice. The issues of lesbians are different from the issues of gay men, bisexuals, transgender, older gay people versus younger gay people. And this program guide gives you a good survey of what these issues are. And as a clinician who has to deal with LGBT people, please be informed of these various issues. It's now being said, I heard this several years ago at a conference where someone said clearly the coming out experience of a gay person in the relationship and the place that has in their development as a psychosexual human being is clearly a trauma. You ever heard of someone going for trauma therapy regarding their sexuality? Yeah. Makes sense, huh? Well, what the SAMHSA did in 13 was to make these 6 columns. And the first 3 are rather negative. The fourth is talking about tolerance, that the gay person is tolerated in treatment, but there's nothing specifically being done for them, right? The gay person is kind of like being treated like everybody else, and it seems fine, and we're talking about mental health issues, but if you're disregarding the psychosexual oppression that the person has experienced, how far are you really getting? And then this is what the development of in the last few years of some programs that's been helpful is LGBT sensitive treatment. And this is programs that will be gay friendly, and they'll have mostly straight people there, or even half and half. And the gay clients get a couple of workshops a week. They call it a track. And this is helpful to a degree. But what the government specifically was asking for in 2013 is LGBT affirming treatment. And this is what we've trademarked as queer normative treatment, where all the treatment components are LGBT specific. The clinicians are picked because of the LGBT experience. The interventions picked are to help with the LGBT experience. The milieu is LGBT. From beginning to end, the program is normative of the LGBT person. There are only several in the country. I'd like to just give you this quote from SAMHSA. And when you're talking about this queer normative treatment model, SAMHSA's comment here is pretty important. When you put it into relationship with ethnic minorities that often experience discrimination, for example, at work or in school, that ethnic minority is able to return to a loving family that typically shares that ethnicity. And so that young person or that working person who has experienced the oppression and discrimination goes home to the comfort of family. This is not true in most cases for the LGBT person. Most LGBTQ plus people go out into the world, school, or work. They experience oppression or discrimination, very subtle sometimes. They don't even know what it is, but it's affecting them. But when they go home, instead of going home to a gay normative home where they can really have a bond and an understanding, a deep way of what that oppression is like, they go home to a heteronormative family. Even if they're accepting and loving and have accepted someone coming out, that person still doesn't have relief on the level of deeper psychosocial issues caused by that oppression. Now, when we talk about trying to move forward in that family system and how to help with the family of birth and the family of choice, I love the word passion. One of the things about developing someone's self-esteem so that they can better engage family and loved ones is to develop passions, real interests in life, to have a family that has things that they share and love deeply about. When we talk about the family system, it must be a process that's always guided by the client. We heal what's ready to heal. This is not imposing on the client a process of transition from drug addiction to healing or mental illness to healing. This is a process that's guided by that individual, remember, who's going out to family. There has to be a constant commingling, a co-occurring issues with the addiction. Often and easily missed in treatment programs is that the depression or the anxiety or the shame has to be treated as much as the substance abuse. A family needs to heal, but it must be on the terms of the client. It must be on the terms of that person who's broken. And in this case, the LGBT person has to be the one who's going to heal and heal when they are ready. If you're going to work with people who are in need of family systems work, the thing that has to happen for the LGBTQ client is an exhaustive, very in-depth substance abuse history and a very clear, exhausted, in-depth sexual history. Now, that sexual history is going to be very abbreviated, just like a substance use history will be abbreviated, if the clinician isn't able to engage in it. If there's some kind of issue in the clinician that doesn't allow the client to be fully truthful and transparent, you're not going to get some of the rich details that you're going to need for this person to really let go of shame and find the freedom of self-acceptance and being able to live in that love that they desire. Now, in queer normative theory, we're not just looking at what's wrong with a family. So if you're doing like a genogram, we're going to talk about the family of origins having strengths, weaknesses, but also we want to look for resilience and patterns of strength, weaknesses, and resilience. So if you have multi-generational great resilience in the family, we want to pull that forward and let the client realize you come from a place of great resilience. You have this in your DNA if it's the family of origin. You have this in the people you're attracted to if it's the family of choice. But you want to pull out not just strengths and weaknesses, but also resilience, which is strength amidst the challenge. It's not just to be strong as a pillar on top of a mountain, but it's to be strong, right? Like the dam against the water, holding it firm. The resilience, the ability to hold, to be, to overcome. Exactly the quality we need in mental health and addiction treatment. See that in the family system and help the client find it in themselves. So in the family of origin, we have to be careful of clinging to preconceived ideals that the black sheep is over there, that they have always been the problem of the family. They've always been different, right? Let go of it. Family may seem like, well, everybody else is heterosexual, everybody else has done well, and here we have an LGBT person and they are an addict. They have mental health issues. When that queer genogram, show the people, places, and things that have been part of a person's life. Emphasize strengths, but especially resilience. That in the family of origin, instead of being pushed, they're the oddball, they're the black sheep, look at how there is resilience in the family and let that be how the client connects to the family, giving a very positive place. Here I just give you some basic steps here to add gifts and strengths. Resilience is connected in very positive emotions. Engage in emotions in a healthy way. Celebrate someone's birthday, even if they offend us, right? Resilience. Be kind to the person who's difficult. Love the one who others find hard to love. Resilience. Even though my brain tells me to pick up, I know better for me not to. Resilience. Resilience is a reordering of the emotional life. For us to be fully alive, for us to be our authentic self, it really has to be built on our ability of resilience, right? Our capacity for resilience. The opposite of resilience is emotional implosion, right? When someone's doing well, and then they hit that point where they fall off and their whole self-esteem falls in and they say, I'm a loser. When I was a student, I conducted as my research project a survey of men in treatment, mostly heterosexual men. And it came up that well over 85% of the men, when given a list of many, many words to choose from, would zoom in on the same word in that list: worthlessness. that they identified with being worthless, loser, nothing to offer. The opposite of authenticity and pride. It is a reordering of the emotional life. Family of choice. The person is identifying with people that will be affirming, that will feel that they belong to. While not all relationships are easy, and that what we referred to earlier, that because of the isolation a person experiences, because of the pulling away, the hiding, the secrets that an individual has in growing up and developing psychosocially, that there may be attachment issues. Hard to find a family of choice, hard to really have that bond. Or there might be a bond, but it's a bond that's problematic, like bonding over bars, bonding over drug use or substance use, bonding over shame-based activities. While this is the case, this is a problem family. It's this family of choice is actually dysfunctional and unhealthy. And now you see, if this is the only place the client has to go to find that affirmation that they don't have from the family of birth, you see where the family work has to happen. It's not always the family of birth. Sometimes it's the family of choice that's unhealthy. That close inner bond. People who are beyond friends, they are now your family. So what also often happens is that a person can go through multiple treatment episodes, right? They can be tagged with different terms like chronic relapser or treatment resistant. I don't believe in this. Queer normative Wildwood theory does not believe in this. We believe that we have to really stand for the person to find authenticity and self-esteem, pride, that they must be placed in that original place of their being, which is a beautiful human being. Many years ago, I was a pastor and I worked in the inner city. I liked working with the inner city. I had a mentor in Mother Teresa. And, working in the inner city was very helpful to me. And I used to tell the kids that preparing for their catechism, God does not make junk. Every one of us is meant to be a full dynamic human being. So that the interventions regarding the family have to have that as the objective. Now we have to be careful of plateaus, that we have sensitivity, that things don't keep change from happening in those families of choice and origin, that we re-engage the system as best we can to make changes where they need to be, so that every person has that engagement, that support that they need from family, whether it be of birth or of choice. What I'd like to do as we end here is to say that moving from shame to pride is about allowing a person to find authenticity. And that for the queer person, that journey from shame to pride is very unique and very different because of what the experience of that individual client is. So heeding the words of Samsa, 2013, Wildwood is an example. Here, one of the clients put a happy face on the barn with the hose and the water. It's about finding that. We use the amaryllis as our logo. Amaryllis in the Victorian age was known as the flower of pride, the bulb that grows strong and tall, and one of the biggest blooms that come to us in the darkest days of winter. This has been a pleasure, and we'll take questions now.
Michael, I just want to say thank you so much. Always great to see you, and just think the world of you, as you know. Also, just wanted to let those that may not know and may remember Father Martin and the old Chalk Talks back in treatment. There was later Father Martin's Ashley, and now Ashley Addiction Treatment Center, and my friend Michael was the recipient of the Innovator of the Year Award this year, and congratulations.
Thank you.
And we do have some questions coming in. And one, is there any literature to further our understanding or education treating the LGBTQ plus individuals?
I would I would start with the SAMHSA material. That big book, it's a good size book. Reach out, get on the SAMHSA website. You can order it. I would put it in the hand of all the clinicians at any program, and that's a good way to begin. And you'll find that there is limited research for the LGBTQ community. There is some research for the gay male population, but gay women have some research. Bisexual persons have some research, but as far as non-binary or trans persons or any other member of the LGBTQ plus community, you're going to find very, very little research. So I'd start with that big book, and then if there was further interest, one of the best things to do is to look at a bibliography from a course being offered in gender and sex programs at major universities.
Okay. And what are some of the best ways to create an affirming environment?
The best way to create an affirming environment is to think of every aspect of your engagement of a client from their point of view. So some of the most nominal, limited beginning things you could do is to put a house plant in your waiting room, and you put a rainbow flag in that house plant. That just said, little tiny message like that sends a great deal to an LGBTQ person. You'll see the rainbow flag in some business windows. That goes a great deal. Here in our town in Madison, Connecticut, someone was just commenting yesterday, a great number of our businesses actually fly the pride flag to make themselves welcoming. And this is a rather conservative fiscally area, but as far as the social dynamic of acceptance and working together, very welcoming of the queer community. Another thing you could do is put a magazine from the gay community that was helpful. Maybe not something that promotes drug use, of course, but proper literature. Go to a queer section of your bookstore and pick up a book that happens to have a queer theme to it and put that on the coffee table in your waiting room, and you will find that people will pick right up on it.
Yes, anything little like that is a big deal. When I was in private practice, I had a little rainbow teddy bear that was given to me by one of the Now Gap reps. And for those that don't know what NowGAP is, that is the National Association of Lesbian Gay Addiction Professionals. Um, that was one of the things that I did just to try to have the environment a little more affirming.
Yeah.
Um,
And of course, David, I should say too, the way that you use your own pronouns. So before I ask someone what pronouns they use, I will say, hello, I'm Dr. Mike. I go by he, him, and his. Um, how would you like to be referred to? And it just sets a whole different tone.
Yeah, and often I just have to just claim ignorance, and it seems very appreciative. If I'm stumbling over something, just go, please help me. I'm trying to do my best here. You know,
That's a good point, David. Is it's better to ask than it is to ignore.
yes. Uh, so, what to do if we are unclear about a patient's sexual orientation, identity, or gender expression?
Well, depends on what level of contract you are with the client. But if you're unsure, uh, one of the things that we do at Wildwood is we get into an exhaustive sexual history, and that's more for the treatment aspect of what we're doing. And we know our population is queer. But if you're not aware of it, it might be something that you just ask matter of factly. Um, uh, do as you're taking the intake notes, simply state what gender marker do you go by? What gender do you go by? And your experiences sexually or your sexual interests. Uh, and if they don't know how to respond, because you'll find a lot of young people will say, well, what do you mean? And well, you have experiences with men, with women, both, and you do it all matter of factly. The trick is to be matter of fact. You don't want to say, you know, well, are you gay? Do you date men or women? Are you gay? You push something and you put a little hook on it. They remember these people are used to hiding, and their antennas go right up, and you're going to get a turtle in its shell. They're going to clam up on you. So you want to just keep open and honest. Just like David was saying, open and honest. Better to ask, hey, sorry, just wanted to get a few notes here on you. And when you get down to gender and sexuality, you just ask. But just be practicing yourself first, right? Like anything, if I'm not comfortable with my own experience of depression, I'm going to be stumbling all over the words of depression with a client. Same thing here. If I'm not clear of how I relate to LGBTQ issues, I'm going to be a mess with LGBTQ issues. I've got to deal with this first. And then I have the opportunity to engage the client and really be of help and productive.
Thank you. And this really goes all the way back to our initial intake screening, which, I'm sure there are thousands across the country that still say gender, male, female.
Yeah,
End of story.
unfortunate.
So, we need to take a look all the way back at that intake form and moving forward for sure. As probably all of us on here know, trying to engage families can be extremely difficult. Um, and I say this respectfully, I said it earlier, we usually don't have the sickest member of the family in treatment often. And I do say that very respectfully. But is it more difficult to engage families um, in your facility than your typical straight or mixed population?
I would say yes and no. right? I'd be like that, because sometimes you will find the most loving family, that they are behind their young person, their family member 110%. But there are many times, and if I would probably venture to say most times, that there's at least a resentment held by parents and by the individual who's going to be treated. And to engage is to talk about system, right? If you talk about system, that we're all moving parts and these moving parts change, even just in the basic experience of treating someone for addiction, the family has to be ready for roles to change, or the recovery is not going to go well. The same thing here. Um, we often have the experience in the queer community that the family isn't accepting. They're paying for treatment, but dad is still calling a trans woman by a male pronoun, and it doesn't intend to change. So yes, it's difficult, but we do our best, and we try to help the person through empowerment find the support they need. So if not your birth parents, you develop those relationships that will be supportive. That's what we do as clinicians. Yeah.
And one thing back to the literature and the staff training, um, at our facility in Florida, I've recently had an old friend of mine that works for Rutgers University that um, is a longtime trainer in the LGBTQ community, and did a two-part series for all of our, not just our clinical staff, but all of our staff, which was fantastic. Uh, there are some good trainers around the country that are more than willing to help out with internal trainings like that. And if anybody ever is looking for that, please reach out to me, and I'll be glad to try to get some resources. Uh, Training for staff is huge. Uh, from the DSM-1 in the 50s, where uh, homosexuality is described as sociopathic personality disorder, we've certainly moved way ahead. But up into the 80s, I believe, Dr. Mike, it was still referred to as a disorder.
Mm-hmm. That's
And
right.
so I think DSM-5 has changed uh, a little again, and so progress, not perfection, and that goes along with our personal training as well. None of us have quite got there where we need to be with our training. Um, so I just wanted to ask about this. Some of the stats that I hear and see, it talks about 20 to 30% of the LGBT community abuses substances compared to the 9 to 10% of our population as a whole. It's a real high prevalence. Um, and then we also know that the majority of the people that need treatment, even a lot of those seeking treatment, can't get treatment. And with the lacking of resources for the LGBT community, that's got to be that much more of a challenge, seeking treatment.
Right. And one of the problems in seeking treatment is as basic as this. You get on the internet and you Google LGBT treatment, and then SAMHSA has a list, and there are literally hundreds of programs that claim to be, on those 6 categories, claim to be LGBT programs, but what they are LGBT tolerant. They will accept LGBT clients, but they don't do anything for the LGBT client. They're just accepting of them. So they accept them into the program, but that's it. That's the vast majority experience of most LGBT people. I'll tell you an anonymous story where not long ago I had a client return, had left us early, didn't stay for treatment. went back out, eventually relapsed, and experienced 20 different treatment programs. And finally, after having a couple of weeks sober, said, you know what, I belong back in a queer program, and came back to us. And had that very experience where just got bounced around in the addiction community, and everybody signing up to use this person's insurance, but nobody really giving queer specific treatment. And this is the most common experience for the gay person. And it doesn't have to be just for a trans person. It can also be for a gay male, just to go through treatment and be known as the gay male, as opposed to a guy looking for recovery, right? That's stigma. Yeah.
So, which kind of leads into the next thing is, stigma, discrimination, hate crimes, emotional abuse, threats, rejection, shame, all, heading down a path of laden with trauma. So what avenues of trauma modalities do you use at Wildwood?
Okay, so Wildwood is considered a trauma-informed program. We have all our clinicians trained in basic principles of trauma dynamics and trauma resolution, PTSD training. And we use a lot of DBT and the somatic form that people are coming to us, and they have been traumatized from early childhood, right? Many of us have our first, whether heterosexual or homosexual, have our first inclinations of gender identity at the age of 4, right? And so from 4 on, if somebody has a proclivity towards transgender or towards homosexuality or bisexuality, that person now will carry that most likely as a secret. And that becomes a compounded trauma over the years in different situations. And what we do is we try to give that person a very simple experiential program where they can re-engage with those fundamental questions of who I am, and rework it and walk through the experience themselves anew. And it might come in an odd form, like your responsibility towards the chickens. And that's going to be a way of just kind of going back to the essence of who you are. And that would be very much a somatic form that we use often, experiential. Yeah.
Excellent. Thank you. I'm not sure how to answer this, but I don't have to because you're answering the questions. So, but this question is, how does one tease apart their shame and their need to self-medicate?
Good. By knowing where the shame came from. By knowing where the shame came from. I'll tell you a story. There are 2 kinds of shame. There's a little girl that walks into an auditorium, falls down, and her dress goes over her head. And everybody laughs and she feels shame. That's a healthy shame. She feels shame because of reaction to other people. Far worse, and the one that most often leads to addiction, is the shame when that little girl walks into the auditorium and falls down and her dress goes over her head. And she feels shame, but there's nobody in the auditorium. She feels shame because of herself. That's the kind of shame that leads to addiction. That self-hatred, self-loathing, that always being on my own, nobody having a relationship with me, feeling isolated all the time, never belonging. That's the shame. So figuring out what caused that girl to trip, what caused her to feel the way she does, and to be with her in it, right? To show her companionship there. That's how you bring someone out. And that was the insight of Bill W. by having AA be a fellowship where you go to meetings in person, where you be with each other, right? That was the whole idea there.
Yeah, I believe there's this part in that, now that you mentioned Bill W., a part in the big book, Alcoholics Anonymous, says that when I complain about me or complain about you, I'm complaining about God's handiwork, saying I know better than God. Um, and which leads into one of my favorite quotes from one of your mentors, Mother Teresa, who I'm pretty confident was Christian, uh, that said that when I spend all my time judging people, I have no time left to love them. And that's one of my favorites, probably of all times. And I think applies very well here. People need to be loved. They need community. They need connection. And I really appreciate the work you do at Wildwood.
Mhm.
It's a wonderful place of healing up there, and just keep up the wonderful work that you guys are doing up there. Uh, I thought it was really funny that you mentioned Provincetown earlier, and I thought about how weird it was uh, for things to be so different because I've been up in Cape several times. We went as a group, a bunch of straight people and a bunch of our gay friends, went to Provincetown, and never once was I looked at strangely thinking, this guy's really odd. He, uh, he's here in our gay community. Nobody treated me differently whatsoever. Uh, but do the flip side of that, uh, like you were saying, people being able to hold hands walking down the street, uh, regardless of their coupleship. Uh, so, I was not judged.
Yeah, exactly.
Yeah, yeah. So thank you again so much. Congratulations again on the Innovator of the Year award with
Thank
Ashley.
you.
And just, I love you guys, and just appreciate the work you do.
Thank you, David. And I appreciate this opportunity. I'm sorry we didn't have time to get into higher power, which is a big, big issue for the LGBTQ community, but perhaps another time. But I really appreciate having this forum.
I hope to have you live in person in Knoxville in the distant future, not too distant future. So
Wonderful.
thank you again so much. I appreciate you guys.
Peace. Bye-bye.